Hello and welcome to our webinar on enucleation. I'm Dan Grelnick. I'm an associate professor from the University of Wisconsin in the Department of Urology. I'm a self-taught holmium laser enucleation enthusiast, and we have put together a fantastic and varied panel of endoscopic enucleation specialists from all over North America. We've been brought together today by Richard Wolf Instruments, the maker of the Piranha morcellator, to discuss our varied approaches. I'd love to introduce them and then allow them a few minutes to describe their techniques and maybe gain some insight into how or why they do the things the way that they do. I'm very pleased to welcome Dr. Ed Karpman from Northern California, who's been involved with green light enucleation, or GreenLep. Sitting virtually next to him is Dr. Chris Manikis with the University of Wisconsin, who's been a prodigious user of holmium lasers and has done nearly 1,000 cases since he started 4 years ago. And last but certainly not least, we have Dr. Naeem Bojani from the University of Montreal, an internationally recognized leader in thulium laser fiber enucleation, or ThuFlep. Just a quick note about me. I became interested in enucleation as an option as I saw increasing numbers of men who were on blood thinners and liked the idea of using a laser that could treat almost any size prostate without much concern for bleeding. I was also interested in options that I could do primarily as an outpatient. And after I started when COVID happened, it was quite a boon for being able to operate when other cases could not be done. I had some friends who were HoLEP practitioners and had decided to move down that road, partially because there was already a high power holmium laser that was in use at Wisconsin when I was starting. I did go watch Dr. James Lingeman and his fellow do 3 cases about a month before I had scheduled my first case. I found the case to be very fun and enjoyable surgery for me, and the patient had an amazing outcome. I thought of it as an endoscopic retrograde version of an open simple prostatectomy, which really helped me mentally get through my own learning curve. I had anticipated doing about 15 to 20 cases a year, replacing the open suprapubics we were doing at that time. But after a year, I had done 70 and had a 4-month waiting list. At that point, we started encouraging others to step up and start doing more. All right. So Ed, tell me, how did you get started with Greenlight, or what are some of the advantages that you see with it?
So got started with green light, and during my residency, I started doing vaporization. So the laser came out, I think, in the late 90s, early 2000s, and that's when I did my residency. So and we had the first experience, I think it was with a 60-watt laser, and then went up to the 80-watt laser, the 120, and then the 180. So I was always on board with green light as a vaporization tool, that would efficiently vaporize tissue. But then when I got into my practice, I started getting frustrated with these patients, like all TERP patients or vaporization patients. The tissue grows back, and it goes back anywhere from 5 to 10 years. These guys would end up in your emergency room with hematuria, with the prevalence of all these anticoagulants. It was more pronounced. And I said, there has to be a better way to get rid of all that tissue. And I was hearing about, I think it was 1999, around there, that Dr. Gilling first published the first report on enucleation, holmium enucleation of the prostate. And I said, that's interesting. And I wanted to look into it. And because I was so familiar with the green light laser, I said, well, is it possible to maybe do enucleation with the green light laser? And then I learned about this guy in Spain named Fernando Gomez Sancha. And he should be given credit for the guy who developed the enucleation technique with green light laser. And I subsequently modified it to suit my needs. And the difference between what Gomez Sancho was doing was what I wanted to do, was that he was doing whole gland en bloc enucleation. So he would literally take out the whole gland, all 3 lobes in one piece, and shove it into the bladder. And I tried that, and it just seemed a little cumbersome. And it felt like, for somebody who's switching from vaporization to enucleation, there's no eject button. Well, what if I got stuck on the left side and the right side came out fine? what do I do? And so all I did was I essentially decided to break up his technique into three different parts. And I decided to start with the median lobe and enucleate that out. And that's very easy to do. And I've trained over 100 guys now on how to do enucleation. And the guys that can get it, they can at least get the median lobectomy, what I call. There's still a lot of difficulty with getting the lateral lobes out for a lot of people. So anyway, so my progression was to go with a three lobe enucleation technique, and I found it easy for a person. Again, I was self trained. We didn't do enucleations in my training, in my residency or fellowship. We did TERPs and we did vaporization. So I had to learn this on my own. And back then, in the early 2000s, there weren't really any training programs. I couldn't. The industry wasn't that involved in it because Homium obviously does not have proprietary, it's not proprietary technology. Anyone can make a Homium laser. So there wasn't a lot of people who were setting up courses, or you could go train with them and to learn about it. So I literally would watch some videos that this guy Fernando Gomez Sanchez was doing in Spain, and I kind of got the gist of it. And again, just knowing my way around the prostate and how to deal with it, I said I could adopt this. So we started with the median lobectomies, and then I would vaporize the lateral lobes, which is what I call the vapo enucleation. And I still do that rarely for guys who have like predominantly like that, that 30-gram prostate, which is all median lobe. So if the guy's prostate is less than 40 grams, it's all median lobe. I've never seen a guy with under 40 grams who's any kind of significant lateral lobe obstruction. But you get these guys who are 20, 30 grams, but they have that obstructive median lobe. And literally on the ultrasound, you can barely see any adenomous tissue in the lateral lobes. And so those guys I would still do I'd enucleate the median lobe and I'd vaporize the lateral lobes. And as my comfort level grew with enucleating the median lobe, I said, well, let's start going all the way around. Since people are doing this, I must be able to learn how to do this. So again, I was self-taught, and I started engaging those lateral lobes in the similar plane. Now, the thing that I did was, again, because I was training myself, teaching myself how to do this, I said, again, I need an eject button. So the nice thing about the technique that I was doing is that initially, like if I'd get the median lobe out, no problem. And if I got into some bleeding or stickiness, I would just switch over to vaporization. That was a nice thing about the green light laser. You just crank it up to 180 watts and vaporize the rest. And but then the technique started getting better and better. And I started realizing that plane is very easy to find in the lateral lobes. And the thing that I did was I would do a 12 o'clock anterior commissurotomy to separate the two lateral lobes, which really did help a lot with the dissection. So just like with Homium or Thulium or any other modality, what I do is after I get that median lobe out, I engage the lateral lobes, and I use a lot of mechanical dissection. So one of the things is I think a lot of people who do Homium laser enucleation, they use that mechanotransduction, that cavitation bubble that forms, when the laser goes off to separate the adenoma from the capsular plane. But the nice thing about the green light laser fiber was that it was this 750 nanomole diameter. It's a chunkier fiber than the Homium lasers, so it actually worked very nicely as like a little dissection probe, like a finger. And when we do enucleations, we just think about it as, we're reproducing the open prostatectomy, because that's what we're doing for open prostatectomy. We make an incision in the capsule, we stick our finger in there, we work it around that adenoma, free it up, and shell it out. Well, with enucleation, you can't stick our finger in there, but we have this nice little laser probe, and it's stiff and it's nice as rounded edges. So I'd use it for my dissection. I'd use the coag feature predominantly for dividing little pesky fibrous connections and hemostasis, and worked very well. And we were able to get all three lobes out very nicely with at the end showing capsular fibers circumferentially from bladder neck to verumontanum, which is, any enucleation has to have that. And so we were able to do that. So we progressed in that fashion. And it was great because then when I started training guys on how to do this was a great like stepwise fashion for them to learn, because most people can't go from TERP or vaporization to enucleation. That's a big leap. And you'd probably agree with that. I see you nodding your head.
Absolutely.
And you're in academics, and so I'm sure you're training a lot of young physicians, and you probably see this all the time. But I would see this in the guys in these experienced surgeons, urologists who are coming out to see me, and these guys would have 10, 15, 20 years of experience with vaporization and terps, yet they couldn't grasp that concept sometimes very readily. And I think with enucleation, it's very important that, you have to have like this three-dimensional mind. And I think people get lost in enucleation because unlike terp or vaporization, where you just kind of shave it down, which is pretty mindless. I used to say it's like, painting the walls of a big warehouse, and you get bored after a while because you're like, oh my God, how long am I going to do this, especially with the big lands? But with enucleation, you really have to have your position in three-dimensional space all the time. And one of the comments I always would get from these trainee guys who come to see me is like, where are you in the prostate? Because they get lost. And you know that there's some people, the way I say this is like, can you take an orange in your brain and rotate it 360 degrees and still kind of keep its perspective? And the other thing I would say is like, some people are good at geometry. They might be great at algebra, calculus, all that stuff, but they suck at geometry. Geometry is one of those spatial things. You need to have good spatial orientation. You might be a great student, smart kid, but geometry takes that extra skill that's different than all the other math subjects that we ever studied, is to kind of know three-dimensional orientation. And that's what I think enucleation takes, is having that understanding of how to like rotate that prostate in your mind and know where you are at all times. So we were able to get this, and I think I locked down my technique around 2013, so about 10 years ago. Okay, and so then we started doing this technique where we would start with the median lobe, and I would demarcate the apical margin with the coag setting, 35 watts. Then I would do deep grooves at the 5 and 7 o'clock position, the bladder neck, and usually the guys with the median lobe, they have a nice little divot there. It's almost like a cut me sign here. And so I would then I would vaporize from the bladder neck all the way back to my apical demarcation. And I would split the crista urethralis at the beginning there and literally use the cystoscope beak, the laser fiber and laser energy just to get underneath it. So the closest that we are to the capsular plane is right behind the verumontanum. So that's where I would love to engage the capsule right there. And once you see the capsule, then you know where you're going. Then you just follow the capsule all the way down to the bladder neck. Keep lifting the adenoma up with the cystoscope beak, use that laser fiber, sweeping it back and forth, and mostly using coagulation. So the study that we published of my first, I think it was 100 patients back in, it was about, 6 or 7 years ago, was really looking at how effectively we can get to that median lobe. And what we found is that you can actually use a lot less energy than expected. So our total joules per gram of tissue is calculated at about it was 500 joules per gram of tissue. So if I had, like, for example, for vaporization, you would need a lot more. So I always quoted the Goliath study. And they needed something like 4,000. Let me remember this. I haven't quoted this in a while, but they needed a lot more energy. So what we found out was we needed about 1,000 joules per gram of tissue. No, is that correct? I'm doing the math wrong here. I need to review that study one more time. But anyway, what we were doing was a lot fewer joules. My point being is, back then when we did this, we were using twice as many joules that I'm currently using. So now we've actually cut that down to about half the amount of energy that we're using because of efficiency. And that's something that's natural when you're getting started with something. You get better at something, you just do it more efficiently. So we're using a lot fewer joules per gram of tissue. And that's very important because when you're using any laser energy, there's always that heat affected zone that is left after you vaporize tissue or you cut it. And that heat affected zone is the inflammatory cascade that you're setting up for after surgery. And this is why guys who get the laser vaporizations have so much dysuria and irritative voiding symptoms, is you're just charring tissue. You're going back and forth. You're burning tissue at 120, 180 watts, And so when you minimize that energy and you leave less of a heat affected zone, patients actually have much fewer dysuria and irritative voiding symptoms after surgery. And that was one of the big benefits that I saw with doing enucleations compared to vaporizations, is the patients just didn't complain. And I think you know what I'm talking about. They call you and they think they have a UTI, the burning, the frequent urination, the bladder spasms, and all that stuff. And that stuff seemed to almost go away when I started doing enucleation, whole gland enucleations, because we just weren't using that much energy. And so, yeah, so for example, back then it was for 100-gram prostate, I would use about 100,000 joules. So it was a 1-to-1. Now we're down to doing 100-gram prostate with about 50,000 joules. So that was the conversion that we did. And again, when we were looking at the Goliath study, I think they were using 4,500 joules per gram of tissue. So a 100-gram prostate would be 450,000 joules that they would have to use. And therefore, that's the difference in inflammation that I would say. So the surgeries have become more and more efficient, and the patients have become happier. I actually had a video that I thought when you arranged this that you wanted to have a video of me doing the surgery. So I had a 185-gram prostate a couple weeks ago, and I said, "Okay, I'll record this one for Dan." And the video time was literally was an hour and 10 minutes for 185-gram prostate.
Is that just enucleation, or is that the whole thing?
Oh, just for the enucleation part and the morcellation. So
Okay.
included.
So
Yeah.
so really the whole case. Great.
Yeah. I was like, what else are we talking about here? After that's done, it's put the catheter in and call for the next patient, you know? Yeah, so it's been very efficient, very good. And now, you know, in my practice, it's 98% of the cases I do are enucleation. You know, I was involved intimately with the development of aquablation. You know, my name's on one of the patents even, you know, and I know the technology very well. And I think it's a great technology, but I still do enucleation because I think enucleation is the most effective way to rid the patient of all adenomatous tissue and to get the most durable results, where, you know, these patients don't have to come back every 5 to 10 years for a touch-up surgery, and you don't have to deal with the repeat admissions to the emergency department with hematuria that a lot of these patients who don't get enucleations will get. And let me say, one of the other advantages that I liked about the green light is the hemostasis. And anyone who's, and I've done homium enucleations, and compared to my green lights, they're just so much drier. Visualization is better. And when we can see better, there's less chance that we're going to do something bad, like put a hole in a capsule or the bladder, or burn a ureter or something like that, or a UO, excuse me, or vaporize or burn something beyond the, verumontanum. So visualization is key. And so we need good hemostasis. And, you know, I think that was always one of the advantages of green light technology is hemostatic compared to homium. But thulium seems to be doing a great job as well with it. And the feedback that I've heard from some people around the country who started using thulium lasers for enucleation is that it's quite amazing how hemostatic that laser is.
Yeah, we use it for some tissue resection, and so I agree with you. Yeah, absolutely.
Hi, my name is Chris Manicus, and I'm an assistant professor of urology at the University of Wisconsin School of Medicine and Public Health. I'm here today to talk about my journey to HoLEP. I first considered adding HoLEP to the procedures I performed for BPH when I joined the faculty at UW. There was a clear need and demand for HoLEP with a long backlog of cases. And quite frankly, I didn't know much about HoLEP. And it was Dr. Grolnick, Dan Grolnick, offered to mentor me through the learning curve. And after 8 years of being a general urology, community urologist, in a non-academic environment, I had this opportunity to learn under Dan, who had at least 50 cases or so under his belt. And it was once we started working together that the program really started to mature. We became comfortable taking on even the most challenging, huge prostates, patients on blood thinners that couldn't be stopped, discharging patients the same day. And it's now by far the most common surgery I do. And after 5 years of this and over 800 cases that I've done myself in a program we're very proud of, we've now done over 2,000 hole-ups. That it's completely changed how I approach BPH. That success wouldn't have happened if it wasn't for a cooperative effort between myself and Dan. And it was a challenge for sure. By far the hardest thing I've ever had to take on, but it's now something that I look forward to. It's now a case I look forward to and look forward to teaching to our residents and fellows. And the patient outcomes speak for themselves. We've always used the holmium laser, the 120 watt, high powered laser. My approach is, to some extent, it depends on the prostate size and shape. For the most part, though, I'll tend to make a posterior midline incision at either 6 o'clock or 5 o'clock, and then pretty quickly get down to the prostate capsule. I like to make an incision just lateral to the viru and then use a combination of gentle blunt dissection to show the plane as it's splitting the adenoma away from the capsule, and then to augment any progress done bluntly with the laser. And this alternating movement of sweeping to show myself the plane and lasering to develop that plane has been very successful, and it seems to be something that the residents latch onto and grasp onto very well. Quite honestly, hole-up is just easier to talk to patients about. It is a quick conversation about what their goals are, and in the vast majority of circumstances, these patients are motivated to undergo a procedure where they only have to deal with the recovery once, probably in their lifetime. They're eager to stop any medications with undesirable side effects. They are very much looking forward to getting rid of that catheter. And the guidelines and the data support the fact that hole-up is better than any other procedure at getting folks catheter free and keeping them that way. So it's a realistic conversation about the recovery. And I think those expectation setting conversations are so important as a patient understands as best as they can that they're going to deal with some transient incontinence, very likely so. They'll have retrograde ejaculation, but they'll have preserved erectile function in the majority of circumstances. And they won't need to be back on medication quickly. They won't need to have another procedure in 2 to 3 to 5 to 10 years.
Great points, Dr. Manicus. And so I have a quick question for you. Hole-up seems to be having a surge in popularity for a technique that's been around for 25 years. Why do you think we're seeing more people get on board now than previously?
I definitely have seen a pretty remarkable interest in enucleation. And I don't think it's one thing. I think there's a combination of factors that include a increased availability of the higher power laser. I think, and then the efficacy of that laser. We are holmium laser folks that have been using the Moses technology for some time, and I do think it makes a difference with hemostasis. And you have guidelines from the AUA now at BPH that fully endorse hole-up as appropriate and safe for prostates of all sizes. And with that, you have patients that are asking for it, and they know the literature sometimes better than some colleagues of ours when it comes to the durability of the procedure, the ability to do the procedure on antiplatelet and anticoagulation, and they're in it. They don't want to have 3 or 4 recoveries to go through. They don't want to be back on medication anytime soon. And so it's a confluence of the availability of high quality equipment a interest in the part of the patient's mature data that says we can do this, do it safely. And with that, there's a surge in demand from surgeons trying to learn it. And that's where I think we have an opportunity to try to lower that barrier to entry to HoLEP. And that's, I know it's a focus of yours and mine, is to try and make it easier to learn, not just for residents, fellows, but surgeons out in practice.
Thank you for allowing me to be part of this webinar. I'm going to talk about bipolar enucleation of the prostate. My name is Nick Warner, and I'm Associate Professor of Urology over here at Mayo Clinic in Rochester. I have nothing to disclose. Now, first, I'm going to kind of go through the procedure a little bit. And honestly, this is very similar to holmium laser enucleation. I was taught first on holmium laser enucleation and then converted to bipolar enucleation back in about 2013. So the operation starts very similarly to an early apical release HoLEP. So I start by making incisions just above the viru. Initial incisions you can see usually result in a little bleeding, but a quick hemostasis there. We'll go lateral to the viru and make our lateral apical incisions here again. We do encounter some bleeding with this operation, but quickly controlled with the coagulation here. And then I do mark out the entire white line of the prostate, as it's called, the junction where the adenoma seems to meet the sphincter, just to release that mucosa circumferentially. We'll cauterize it here first, and then once I'm happy with the residence markings, I'll allow them to dive in and cut into it. The goal here, of course, to leave a thin rim of mucosa right near the sphincter, while also separating the mucosa from the adenoma to prevent shearing on the sphincter during our remaining dissection. And everybody's pretty familiar with this. One advantage here, I think you can really see that loop dives in nicely, working laterally, freeing the mucosa from its underlying adenoma attachments and, more importantly, the sphincter. We'll carry this circumferentially all the way around. Once I'm happy that we're free and the mucosa is safe at the level of the sphincter, we'll move on to the remaining dissection. And here you can see this is very classic enucleation, both the mechanical and electric cautery where necessary. The majority of the work is done bluntly in a forward direction, always moving away from the sphincter rather than towards the sphincter or lateral. I try to do as much forward enucleation as possible. I can either use the beak of the scope or this loop, which is pretty durable, to do the enucleation. And this can be done with any product, Wolf, Olympus, Storz, whatever energy source you have available, you can do this operation. Normally, when I'm going through the learning curve process or encouraging others to go through the learning curve, I recommend that they stick to 80 to 100 grams, whatever they'd be comfortable resecting if necessary. Just in case they do get lost, you can always convert to a TURP, and generally that's going to be a very effective TURP in these populations because we have started the apical enucleation. So here you can see we're entering the bladder neck, very similar to what you'd see with a HoLEP. This is an en-bloc technique, but I've found it easier to split the lobes at 12 o'clock before forcing it into the bladder. Otherwise, a very traditional enucleation procedure. Now, why do I choose this technique? Well, first, honestly, it was out of necessity. I was working at the time in Phoenix right after I finished my training, trying to do HoLEPs, and we were renting the equipment from Luminous at the time. And the equipment, especially the morcelator, was being shared between 5 states. And it came to a point where I was able to do HoLEPs 3 days a week, or sorry, 3 days a month. And it was hard to keep up my skills. And then I saw some videos of people doing bipolar enucleation and adapted this technique and found it instantly easier and, again, more available than the HoLEP. The other thing is that, as you can see in that video, I think we really get good perspective with this operation. Whereas with the HoLEP, I feel like everything's right in your face. Having the ability to push that loop out that inch or so really gives you the ability to see point A and point B a lot better than I could with a hole up. And I found that this was actually easier to teach as well. Essentially, if you keep your loop in the direction of your capsule, you could walk into a room and essentially know where everybody is operating at that moment. Whereas with the laser enucleation, I think it's easy to get lost, especially when you try to come over the top of the prostate. The last thing I'd say is it's still a learning curve. I still think it takes about 20 cases for most of our residents to become proficient at this. But the difference is it's a gentle learning curve. And what do I mean by that? Well, during the learning process, if you're comfortable with your TERP, the patients will benefit from a TERP after enucleation, or even a partial enucleation, because you're going to really get down to the capsule at least at several points in the prostate, and they're going to have an excellent outcome in that situation. Just my own personal experience, sort of some horror stories as far as doing the whole EP. We had one patient I vividly remember, 120 gram prostate early in my process, that we had to do 2 different times, and I tried to convert to a TERP at one point, but the hospital didn't have the equipment available because another surgeon was using the instrumentation, and ended up being 2 or 3 operations that were 2 to 3 hours long during the learning process, and that was after I had already done 50 whole EPs. So definitely still a learning process there, but having this ability to quickly convert to a TERP when you do get stuck is a real advantage to this operation. What do I think are some of the disadvantages? One, some of the equipment really produces a lot of bubbles. I think with the hole up, you still get bubbles, but they tend to be very small. Some of the Olympus devices, for example, will make these large bubbles. I haven't had as much problem since they switched to the Wolf resectoscope. I think the end firing of the laser is actually better for the apical release because you are allowed, it's easier to leave a little bit of the adenoma behind. Whereas the way I do this with the mechanical enucleation, I have to be really precise where my mucosal release is. If I'm not close enough to the sphincter, as I come around bluntly, we are going to shear still some mucosa. I guess here what I'd say is that since I've really started paying more attention to the apical release and focusing that even if the end product looks the same as it did when I wasn't doing a great job with the apical release, my incontinence outcomes are better. Just paying attention to the sphincter, I think, really gives you that less tension on the sphincter and is going to result in better early incontinence rates. The other problem is disadvantages with the prostate chips. Really, sometimes if they've got a real thick anterior commissure, when I'm cutting through that with the loop, I get a lot of chips floating around, and that can definitely get in the way. Here, the hemostasis, I think, is definitely probably better with the lasers. But clinically, where does that matter? And I would guess only in patients who are on active coagulation. The examples I'll use is those who are on mechanical heart valves, and we have to put them right away on heparin afterwards. This is a population I've had a little trouble with. Otherwise, my catheters come out the next day, sometimes the day of. We sent patient home during COVID. I tend to like to keep patients just because they're coming in from so far to see us. I like to keep them overnight and take the catheter out early in the morning so they can urinate before they leave. And that's easier on them than having to go to the hotel and then come back to the clinic. But really with active anticoagulation, I do believe there's a favor toward the lasers. That's all I have. Here's my Twitter handle as well as my email if there's any questions. Thanks again for allowing me to participate. So in answer to the question, why hasn't bipolar enucleation taken off in the United States like it has everywhere else in the country or in the world? First thing I think is just education. About 6 years ago, 7 years ago, I guess 8 years ago now, when I first got to California, I'd already been doing the bipolar enucleation for about 3 years. And we had met with the Olympus reps, and actually none of them out in California had really heard about the bipolar enucleation. And so I think there's just this lack of knowledge that you can do this enucleation procedure with the resectoscope equipment. And the other would be that I think with anything in American medicine, if you follow the money, you probably have your answer. And really the people that were promoting enucleation early on were the laser companies. So Luminous and Boston Scientific selling their laser fibers and their high power lasers in order to promote the procedure. Well, whereas I don't think anybody was really taking it on from the bipolar energy source, just because we already had loops out there. Everybody was already buying loops for their 2 RBTs. During COVID, there was this online education series out of San Francisco, but Mike Borofsky was doing a talk, and I really like this. At the end of his talk about holmium-associated enucleation or BPH surgical options in general, to a bunch of residents around the country, he surveyed them and asked them what was their preferred approach for, let's say, an 85, 90 gram prostate. 70% of respondents, even for an 80 gram plus prostate, still said they would do a TURP. And if I told people that you can do an enucleation with the same equipment you do a TURP, but do a far better job for the patients and give a longer durability with better, superior outcomes, which is well documented in the literature, I think that's the kind of message I want to get out there. And then the other message I want to get out is just the education process, the learning curve. I think for somebody who's comfortable with TURPs, to go from a TURP to a bipolar enucleation is a very easy process. And I have many examples of that, of the training we did over the last 6 years in California, of people coming and being able to adopt this within 5 or 6 cases pretty reliably. And then I did mention about the gentle learning curve. Start the enucleation, do bits and pieces here and there, and then as soon as you're comfortable, you make it further and further each time until you get the whole enucleation done, at which point you can switch to morcellation. Otherwise, just do a nice resection, and probably going to be one of the best TURPs you've ever done. So again, thanks for your question.
My name is Naeem Bojani from the University of Montreal, and I'll be presenting thulium fiber laser enucleation of the prostate. The main objective of this video is to give you a stepwise approach in performing a enucleation procedure with the new thulium fiber laser. I will be demonstrating an en-bloc enucleation procedure. The new thulium fiber laser has a wavelength that is very similar to the holmium YAG laser. However, this difference increases its absorption in water by 4 times compared to the holmium YAG laser. The case I will be presenting is a 72-year-old gentleman with a past medical history of hypertension. He has been in retention for 3 months and has failed trial-avoid twice. Here is the MRI of his prostate, which has been measured at 153.4 grams. Here is the endoscopic view of this patient's prostate. As you can see, he has a small median lobe with 2 large lateral lobes. I like to begin my enucleation about 1 centimeter proximal to the verumontanum. So you can see here very easily the verumontanum and the 2 lateral lobes. So my enucleation will begin 1 centimeter proximal to the verumontanum. My initial laser settings are 0.5 joules and 60 hertz with the short pulse. A few things to note here. First is I rarely touch the tissue. I'm usually about 1 centimeter away from the tissue. This is in contrast to enucleation procedures using the holmium YAG laser. As well, you'll notice that there's very little bleeding, and this is due to the fact that this laser is very well absorbed in water. Here we encounter some stones which confirm that we are in the enucleation plane. Now that we have developed our enucleation plane, we can begin the enucleation around the apex of the prostate. This can easily be performed by pushing slightly on the prostate and by cutting the attachments of the prostate to the capsule with the laser. Again, you'll notice that I'm using the no-touch technique in order to avoid any carbonization and to facilitate the splitting of the tissue. The objective here is to get over the top of the prostate to 12 o'clock and ideally over to the other side. Once we are over the top, as you can see here, we will then head proximally to try to enter into the bladder. Here you can see the bladder neck and its attachments to the prostate. Once we pass through these fibers, we'll be into the bladder and we can take down the rest of the attachments. Now that we have entered into the bladder, all that's left to do is the lateral and posterior enucleation in order to place the prostate into the bladder. For the lateral and posterior enucleation, I changed my settings to 1 joule and 60 Hz, again with the short pulse. As mentioned, you want to use that no-touch technique and really stay at least a centimeter away from the tissue and let the laser do all the work for you. As you can see, the tissue separates extremely well with this laser with minimal carbonization and excellent hemostasis. Once you have completed the lateral enucleation of the right and left side of the prostate, the next step is to focus your attention on the posterior aspect in order to lift up the prostate and push it into the bladder. The final step is morcellation using an oscillating morcellator. It is very safe and effective. The important aspects of morcellation is excellent visualization, a very full bladder, and keeping that prostate in the middle of the bladder. Thank you very much. It has been my pleasure to present thulium fiber laser enucleation of the prostate.
Dr. Bojani, as we see thulium fiber use increasing around the world, and the buzz about it is increasing as well, what do you see as the greatest advantage that thulium has in the long run for those people who are trying to choose one laser over another?
Thank you, Dr. Gralnick. I think that's an important question. In urology, we have so much new technology, and one of the main new technologies that we have now are lasers. And these new high-powered lasers are really pushing the field forward. And so, I got my thulium fiber laser about 3 years ago, just around the time of COVID, and we started sending patients home the same day of the procedure. And I think the thulium fiber laser really allowed me to send my post-enucleation patients home. And I think one of the main benefits of this laser is its hemostatic properties. It really is an excellent laser for hemostasis. I use 1 joule and 60 hertz, as you saw in the video, and I rarely have to use the second pedal because the hemostasis is just so good with that first setting. So I would say for the thulium fiber laser, for those who are considering upgrading their laser, I would suggest the thulium fiber laser because of its hemostatic properties, allow you to do the case with very little bleeding, allow you to send the patients home relatively soon, if not the same day of the procedure. So that would be my recommendation on why I have switched over from the holmium YAG laser to the thulium fiber laser.
Well, I thought that was a fantastic overview of different techniques, and I'd like to thank our panelists for their insight. Thanks for Dr. Naeem Bojani, who prefers thulium fibers, Dr. Ed Karpman, representing Greenlight, Dr. Nick Warner, who uses a bipolar loop, and Dr. Christopher Manicus, the holmium specialist. I'd also like to thank our sponsors, Richard Wolf, not only for putting this together, but also for their Piranha morcellator, which saves me and my patients time in the OR. I think we will see a rapid and sustained rise in the employment of all anatomical enucleations for BPH and lower urinary tract symptoms. As you saw here today, whether we employ bipolar energy or one of the various laser-based procedures, enucleation is enucleation. Thank you very much for watching.
Richard Wolf, Spirit of Excellence.